tissue. But Dermapure is 100% human dermal tissue from a cadaver, okay? The cells are removed, and that's the word decellularized, okay? Is it approved by the FDA? If you get asked by a doctor, is it approved? Well, it's registered yearly by the FDA. That's all that it has to be because it falls under an HCCP Section 361. To be in that category, two things need to be in place. Your product has to be minimally manipulated and for homologous use, and Dermapure is both of those things, okay? So Dermapure can be used from head to toe for replacement of integumental tissue and when implanted to provide soft tissue with supplemental support and or protection from mechanical stress, okay? So it can be outside the body for wounds and also implanted. This next slide, you'll see if you took a pluck of skin from your arm, you're seeing a side view, shows you the layers of what Dermapure is and is not. You have two layers of skin. You have the epidermis and the dermis. Within those are several layers, right? Multiple layers, but you only have two layers of skin. Dermapure is not the top layer, epidermis. If you look down at your arm, you're looking at the epidermis. That is removed in processing. But it does contain the membrane, the basement membrane, like a membrane in between the two layers of skin. And because of that basement membrane, it has the ability to re-epithelialize and form the epidermis. So in this picture, you see that purple dotted line. That would be the basement membrane. And then underneath that is the dermal layer. The dermal layer has multiple layers. But it has papillary layer, reticular layer, and within that is multiple layers, okay? Now, down at the bottom picture, you're going to see our regular Dermapure. And then we do have another offering where it has precise cut holes throughout. It's what we call Dermapure Meshed. The Dermapure Mesh allows for drainage from a wound to escape out, okay? And it also allows for expansion of the graft and for it to become larger. I'll give you one example. It comes in two sizes, by the way. The Dermapure Mesh comes in a 4x6 centimeter or a 7x10 centimeter. So if you had our regular, by the way, the regular Dermapure comes in multiple sizes, all the way down to a 1x2 centimeter up to a 9x12, okay? The mesh, two sizes. The 7x10, if it was not mesh, would cover 70 centimeters square. But if you had the 7x10 mesh, it would expand out 1.8 times. Not twice as big, but 1.8 expansion. So 70 times 1.8, you could cover up to 126 centimeters square. You'll see a picture of a wound a little later with mesh. So how is Dermapure different? What is our differentiator that sets us apart from other allografts? It is our technology, our processing called D-cell technology. It's the way that we remove the donor cells and other things. So let's go through these steps. This is the differentiator. What do we have that Graft Jacket doesn't have? What do we have that AlloDerm doesn't have? Our unique proprietary processing only to tissue regenetics. It's called D-cell technology. Number one, we utilize a low concentrated anionic solution, SDS 0.01%, to remove the donor cells and cell debris. Two, we incorporate a nuclease treatment that results in greater than 99% of DNA removal from the donor. It's not 100%, but it's close. Greater than 99% removal of the cells from the donor. Number three, we utilize protease inhibitors to preserve the tissue structure and biomechanical properties. So that little picture that you see by number three would be one of those tissue structures, open intact vascular channels. So your skin is a highway of open intact vascular channels. You have cells flowing through your skin. Dermapure still has those open intact vascular channels, and largely due to the use of protease inhibitors, preserving them. Okay, it also Dermapure still contains over 800 proteins, collagen, laminin, fibronectin, heparin, growth factors. Those are necessary. Those are still preserved within Dermapure. Protease inhibitors also protect biomechanical properties, such as the strength of Dermapure. Your skin is very, very strong. It's the largest organ on your body. Dermapure is a thin profile, but it is very, very strong due to protease inhibitors. And number 4, Dermapure is terminally irradiated, neutralizing and eliminating pathogens, providing microbial sterility 10 to the negative 6. So guys, this is the differentiator. You really need to know D-cell technology. That's what sets us apart from other allografts on the market. This next slide, you'll see some of those other allografts. These are all allografts: AlloDerm, Graft Jacket, Repliform, Dermacell, Arthroflex. And you can see every company has their own unique recipe, if you will, their own way of processing their donated tissue from donors. And you can see it's not all the same. And here's the 4 key fundamentals of D-cell technology. And you can see not everyone processes just the same. We believe that's what sets us apart. This next slide shows you residual DNA findings derived from a literature comparison of studies using the Pico Green fluorescent assay to determine DNA content in D-cell tissue compared to cell tissue. So you're looking at the bottom of 4 allografts: Dermapure, Dermacell, Graft Jacket, and AlloDerm. Now this was done back when Graft Jacket is no longer, this may not be current because now, just recently, Graft Jacket is produced by Allosource. Used to be produced by LifeCell. And so now it's produced by Allosource. So this number could be different. But this is what you're looking at, is how much leftover residual DNA from the donor. Dermapure is 1.26 nanograms per milligram of dry weight. Hardly any leftover DNA. Dermacell 15.97. At this time, when this was done, Graft Jacket was 134.66, and then AlloDerm was 272. So significant amount of residual DNA. Well, why does that matter, Dana? If I was asked by a doctor, well, the more DNA left behind, the more likelihood of a possible inflammatory reaction to occur, or even rejection. I talked to you earlier about the vascular channels that are still within Dermapure. Those are very, very important. And that is why, under the clinical evidence that we do have in 2015 by Dr. Ardeshir Byatt and his colleagues, they were able to determine that you could get great graft take within 7 days due to these open and tap vascular channels. The patient's own endothelial cells and fibroblasts could quickly access those channels, migrate and proliferate through there. So, doctor, when you put Dermapure on this wound patient today, you should expect great graft take within 7 days due to open and tap vascular channels in Dermapure. We have clinical evidence showing that. It was done in 2015. Please stop me if you guys have any questions. So I brought up that study. So, you'll be asked by doctors, clinicians, do you have clinical evidence? We do. It was done in 2015 in the UK by Dr. Ardeshir Byatt and his colleagues. And they wanted to look at angiogenesis, which is comprised, just say granulation tissue, new granulation tissue. They also wanted to look at scar tissue or fibrosis. So they did a study, a 6-week study, and they signed up 50 healthy humans, med students actually. And they said, hey, we're going to create wounds, 2 on each of your upper arm. We're going to do this study, and we're going to compare Dermapure to a well-known xenograft, Integra. We're also going to look at Dermapure and use the patient's own tissue, an autograft. And then one of these wounds, we'll leave it open and look at really how it fills in, but also scar tissue. So what you're looking at is that study on day 28. So they enrolled everybody, they lined them all up, they punched their arm between the shoulder and the elbow. They created 2 wounds on the left arm, 2 wounds on the right arm. On the left, let's say they took out 5 millimeters and placed Dermapure. A few inches down, they took out 5 millimeters and they left it out for 2 minutes and placed it back in. That's an autograft. On the opposite arm, they did not place Dermapure and the Integra on the same arm, which makes good sense. But on the other arm, they took out 5 millimeters on the inner aspect of the upper arm and placed Integra. 2 inches down from that, they took out 5 millimeter section and left it out. It's called secondary intention to heal. So this clinical study was done, lasted 6 weeks. After that initial day, they broke the group up. Well, they lined them up and broke them up into 5 groups of 10. And every week thereafter, they took one group of 10 and did an additional biopsy, or wound, if you will. Slightly larger, it was 6 millimeters. And we're looking at day 28, so week 4. One of the groups of 10 at week 4 is what you're looking at. You look at the picture at the bottom is the autograft, the patient's own tissue, represented by, you can see an A, and then Dermapure is DCD, decellularized dermis, and then Integra would be the CG. Now what you do notice is that the autograft and Dermapure so closely resemble each other that they really couldn't even tell Dermapure from the native tissue. They both contain this dark purple area called the neodermis, which is necessary to reepithelialize and form the epidermis. They both contain these up and down bumps called reedy ridges or reedy pegs. That's also necessary. What you see with Integra is no neodermis, but you see a thick band of scar tissue, and that was evident throughout the 6-week study. They could tell exactly where Integra was. And well, it makes sense. Integra is a xenograft. It's bovine, shark cartilage. It's not human to human. It's not the same architecture. By the way, Integra is not a one-and-done shot. If they use Integra, they're going to have to do a secondary dressing. Dermapure can be a one-and-done. So why does this matter? Why does all that matter?
Dana, can I add something on the
Yeah.
Hey, so one thing I like to interject in this training here on the studies. So I've worked for companies that have had, so-called studies before that are really just marketing pieces. We have 2 studies done by clinicians in the UK, a plastic surgery group. They're done on our competitor, our number 1 competitor. They're compared against our number 1 competitor, which is Integra. And then they're also done on human subjects. So very rarely in my career have I ever had studies that were actually done on human patients compared directly to a competitor, as well as an autograft, which is the gold standard, with very favorable results. So these studies when using these studies, I do often send the whole thing, but we also have summaries of them, and they're very well received just because it's a very credible study. So
Yeah.
Go ahead, Dan.
Yeah. Yeah, and one thing I might add to this, it was for 6 weeks. And like Jason said, rarely do you have a neck-and-neck study with a competitor. You just don't see that very often. But in the 6-week study, Dermapure had increased angiogenesis and decreased scarring compared to the others. The autograft really only had to reestablish a connection. So Dermapure is very diverse. It could be used from head to toe. It could be used outside the body for wound coverage, for tissue replacement, but also for that, implant area, added tissue supplementation. Okay? Most patients only have to receive 1 application. Okay? So this is anecdotal evidence. It's what we found with multiple case studies that we have. Okay? The clinical outcomes have been superior, but not only that, Jason can tell you, and he deals with all the pricing and the sales questions, but it's also very economical. And Jason can tell you most of the time is better pricing than what they're currently getting, even with like Integra. So again, in that clinical study, Dermapure outperformed. It had enhanced angiogenesis, new tissue fill-in, and reduced fibrosis or scar tissue. We're going to cover the instructions for use and a few other clinical considerations. The preparation, guys, is very, very simple. So it's stored now in the supply closet in envelopes because we listened to the customer and they said we don't have a lot of room. We went from small boxes now down to sleek little envelopes, okay? When they take it out of the envelope, the first package they removed, it's not sterile, but within that contains a sterile package of Dermapure. They take it out of that and they drop it into 400 cc's of saline. So are they hydrating it? No. They are just rinsing off glycerol. I told you that Dermapure, one of the steps of D-cell technology was that it was sterilized 10 to the negative 6. So if doctors may think, oh, you're gamma radiating it, sterilizing it, but we coat it with a substance called glycerol that protects it before it's gamma radiated. We want to protect that scaffold, those proteins and collagens, laminin, those vascular channels. They're protected. It's coated with glycerol. That is the only reason they need to rinse it off. The IFU says 10 minutes. They're rinsing off the glycerol. Okay? The scrub tech can even feel it, agitate it with his hand a little bit. He'll feel it sliding right off. Orientation. Yes, as I mentioned earlier, we do recommend the tissue tab on the upper right-hand side. When the tissue tab is on the upper right-hand side, that means the dermal side of Dermapure is down, and the basement membrane is what you would be looking at. Remember, the epidermis was removed. So they're looking, if the tissue tab's on the right, they're looking at that basement membrane. Dermis down. That's how we recommend it for implants and also for wound replacement. On this patient, you can see the doctor even wrote, I can see the tissue tab on the upper right-hand side, but he even took a surgical pen and wrote up on it. And then he twisted it around, sewed it on, okay? They can use scalpel or scissors. Of course, for implants, they're going to just use absorbable sutures. For wounds, we do recommend, if they have a wound, that they put slits in it, or what we call fenestrations, pie crusting, different doctors call it different things, or they can mesh it with the hospital mesher. Every hospital has a mesher. They usually have 2 because they clog. But we even have a 4x6 centimeter and a 7x10 already meshed. So that's what I would be out selling to my physicians for wounds. It makes life so easy, saves them time in the OR. Time is money. But if they didn't have that, case popped up, and they have regular Dermapure, they can take a scalpel and put some slits in it, like this doctor did at the bottom. You want Dermapure pressed down against the wound bed. He even put a suture down in the middle of this because it was on a hill. Again, the tissue tab needs to be on the upper right-hand side. The mesh even has a tissue tab on the upper right-hand side. I like to throw this in right now and tell you, if they cut this tab off, and it's gone, and it's just one rectangle. Dane, I don't know which side's which. Hey, take some blood from the area you're prepping, place it on both sides of Dermapure, and the dermal side will absorb the blood and turn reddish. The basement membrane would just want to wipe off like it would on the top of your skin. This area would want to repel off. Once they've placed it on the wound, we do recommend staples or sutures. It's the best way of securing it so it doesn't shear off. Okay? Once they've done that, you can see how it's pressed down against the wound bed. It needs to come in contact with the vascular bed of that wound. This person was an 11-year-old patient at the bottom. They sewed 2 pieces, 2 7x10s together. He did not have the mesh, which would have been great, but he did put some slits in it to allow drainage to go out, so it doesn't pull underneath it and form a hematoma or seroma. That's the reason for those holes. For a wound patient, the drainage has to have somewhere to go. It needs to go out. Otherwise, it's going to jeopardize the graft from taking. So once they've sewn it on or stapled it, we would recommend a non-adherent contact layer. I'm going to tell you a few examples. Smith & Nephew has Adaptic. Monlica has Mepitel. There's Medline, Y-Mesh Vaseline gauze. There's different ones. Whatever the facility has, they would place that over the graft and the staples or the sutures. The reason for that is after it's left on 5 to 7 days, you don't want it drying out and pulling the whole graft off when a nurse takes the dressing off. or even the doctor. So once they place this non-adherent, some doctors, I will tell you, will even put an antibiotic of their choice, a smear on top of that. They want to keep the graft, you want to keep it good and moist. We do recommend a moistened bolster dressing. So they would take Kerlix or gauze, moisten it in the saline, and place it on the non-adherent. And then wrap it up with a secondary dressing, the date, the time, their initials, they know. Leave it in place. We would recommend 5 to 7 days. Dana, can I use a wound vac on it? Doctor, if that's what you normally do? It works great with grafts. We would recommend a non-adherent, then the wound vac foam, or the negative pressure device you're using, a non-adherent, their foam, 5 to 7 days. Any questions? Very easy.
Yeah, I hope some people have some questions, because the stuff we just went over is really, really important for how things are going to heal after the case. It seems pretty simple, which it is, but people do mess it up as far as, especially the orientation of the graft, how you secure it and all that stuff. It is pretty simple, but it's very, very important to know that out. And then I get questions still in cases by doctors all the time. If we don't have the mesh, they ask if they have to put a hole in it in there. And the answer is yes. In these grafts, as Dana said, every wound needs to drain. If the drainage doesn't have a place to go, it's going to affect how the graft adheres. And with the whole first 5 to 7 days is just to make sure it adheres. So it's really important to know that. And they can't put too many drainage holes in that graft if they're doing it with a scalpel. They just can't. So just make sure you know that, and that screen right here is really important. So any questions?
I got one real quick. Can you go over what you were saying about if they cut the tab off?
Yeah. So let's see the tab here. If they cut it off, and it's like, Dana, which side's which? I mean, this has happened. I've been in the OR when that's happened. It's like, hey, just take some blood. They're going to be prepping the area, even for an implant. They're going to have blood, or for a wound, they're going to be what we call debriding it or prepping it. Hey, just take some of the blood there with your gloved hand and place it on both sides of the graft. The dermal side, it even has a different feel, guys, but the dermal side of Dermapure, it will absorb it and turn reddish. The basement membrane, that outermost layer, it's going to want to wipe off. Kind of like if you dropped some blood on the top of your arm right now and you wiped it off, you could maybe get it all off. Well, on the dermis, it's going to want to soak in, absorb, and turn red. Okay? It's called the blood, and it's in the IFU as well. It's called the blood test. And that's really almost with any allograft, you can do that for other companies I work with. So this is the reason it's very important, like Jason said, because this patient down at the bottom, they did not put in these slits in Dermapure. It was not the mesh. It wasn't a huge wound, but he had a lot of what we call exudate or drainage, and it pulled all underneath the graft. Dermapure did not take in this case. It needs to be removed. His foot is what we call macerated, just soaked. Okay. Now up here you can see the doctor took a scalpel and made slits. Sewed it on. It's pressed down. He would need to put his adaptic or his non-adherent and then moisten gauze and go. Like I said, some doctors will even take bacitracin or whatever antibiotic they want. By the way, don't be freaked out if some of the doctors use vancomycin in the basin that they soak their grafts in, or they have certain antibiotic solutions they want to do. That's their call. We just recommend in the IFU saline. Okay. You can see this one. Oh, this overlapped on good skin. That'll be debrided off later. What we call debrided, that'll turn black-brown. Can't skin on skin won't take like that. The doctors know that, but it's not going to hurt anything. That'll come off later as they're cleaning it up. Doctor took some slits, and you can see that, and even a few sutures to keep it from wanting to balloon out. It's on a heel, this one. Yeah. So why does moisture level and dressings impact the appearance? Well, if the basement membrane, that outermost layer of Dermapure, gets too dry, it will become black and brown in color like this one on the right-hand side of this picture. That's otherwise known as a scab. Okay? If you go outside and rub your hand on the sidewalk and take off your epidermis, and it dries out, you're going to have a scab. And that's what this is, okay? It's not necrotic tissue. It's not dead. Now, doctors know, anyone that's been dealing with wound and grafts, if it has a horrible odor, mushy, boggy, smelly temperature, that's a different story. Then they would remove the graft, okay? But this just dried out. This wound did not have a lot of drainage, evidently. Didn't have a lot of exudate. And the dressing they put on top of this Dermapure, they might have used dry gauze instead of moisten it. Okay? And some doctors, to be honest, even like it when it does this. It's still adhered down. That's the key word. 5 to 7 days, when they remove the dressing, take it off of Dermapure, what they should see is that Dermapure is adhered down, stuck down, not pulling up, okay? This wound here, this doctor elected to use Steri-Strips. That's his call. Hey, he's been doing this a lot longer than us, right? And he's gone to school for this. So if he wants to use Steri-Strips, that's his call. It's not contraindicated. This was a tunnel tract wound. Had a lot of exudate, stayed really moist. Maybe they used a lot of moistened gauze on it. It did well. In both of these cases, Dermapure was stuck down. Okay? You can even see on this one on the right where Dermapure just shrunk away from the edges. Is that okay? It's still filling it. The dermis is still adhered down. The patient's own cells are proliferating, migrating through there, and the wound is getting smaller. Okay, so it's fine. So I told y'all earlier what the mesh looks like on a leg. This is a snippet from case studies that we have that'll be on our additional training website that should be up and running in another week. We're just doing a lot of additional updates and adding more to it. But this leg, this gentleman was a 58-year-old gentleman out of Memorial Hermann Hospital, Houston, Texas. He was wade fishing somewhere in Galveston, the Gulf somewhere. He was a diabetic. He come in contact with Vibrio, otherwise known as flesh-eating bacteria. The condition's called necrotizing fasciitis. And the bacteria really just ate away at his leg. Okay? To save it, they had to clean out and debride, and yes, he was on, I'm sure, long-term antibiotics, several. But he was down to muscle, tendon, ligament, and even bone, and it was circumferential all the way around his leg. This picture's small, okay? This is a large leg. He received 6 or 7, I believe, on the case study. By the way, on our website, you will see all these case studies, not the little clips. You'll see the whole write-up. 58-year-old gentleman presents to, yada, yada. It'll go over intra-op findings and also the summary of the surgical report. So we don't have the initial at week 0 when they clean them all up and put Dermapure on, but we have week 2 picture. This is the 7x10s. Like I said, he had 6 or 7 7x10s. So that covers, they expand out all the way up to 126 centimeters square. So a large wound. That's a tattoo that you're seeing at the bottom right there. So you can see large wound. He needed depth fill. His leg looks deformed up here, right? Well, look at week 4. Where's Dermapure? It's incorporating, integrating. It's disappearing. That's what you want to happen. You also see his leg taking on more of a normal shape. Okay, that's week 4. But remember, he's a diabetic. Okay? We don't know his blood sugars. I don't have all that information. So diabetics are slower to heal. Week 5, his leg is looking even, like I said, you barely see any pieces of Dermapure, maybe a few. It's integrating, almost fully integrated, and he has a more normal appearing leg. In week 7, his leg looks almost filled in. A lot of depth fill with one application of Dermapure. It covered up a lot. Muscles, tendon, ligament, bone. He did elect to do a split thickness skin graft and take skin from the, I believe, his other thigh. When you have a leg wound this large, their goal is, let's hurry this up. A split thickness skin graft contains epidermal cells, keratinocytes, and it speeds up the epidermal epithelialization process a little faster. So but we do have case studies where all they used was Dermapure, one and done. Well, this one, a little different, but this I believe he was 28-year-old, had a traumatic injury, open tibial fracture with degloving of the soft tissue. You can see they even performed a fasciotomy on his leg because of the swelling. That's why they do that. So when it was time for the external fixator to be removed, and they sewed up the fasciotomies, that could have been on the other side. I didn't do this case study myself. I work on a lot of these, but this one I did not do. But he still had a big deficit of tissue. You cannot take skin from here and pull it up to here. He had to have grafting. If it was on a belly, that might be something different, but this is an area that's going to have a graft. Doctor just took a scalpel, made slits in Dermapure, and stapled it on. 1 application of Dermapure. Week 2, Dermapure's disappearing, and this is at week 2. You can see the difference, but also the age makes a difference. This person was not a diabetic too. At week 8, his wound is closed. 1 application of Dermapure. These are just 2 snippets of multiple case studies that we have, and they'll be up on our Distributor Depot website soon. This next thing that you're looking at is a clinical appearance guide. It just shows you some before and afters of Dermapure, fully integrated, partially integrated, moist wounds, drier wounds. All these were normal. Okay. This is the middle column, is that little boy, 11-year-old, where they sewed the 2 pieces of Dermapure together on his leg. He ended up doing beautifully. But this is just showing these dark brown areas. Dermapure can dry out. Maybe the drainage seeped to the bottom. Maybe they used drier gauze instead of moisten. He still did fine. Here's that tunnel tract wound with the steri-strips, and you can see Dermapure just disappeared. In all the cases where Dermapure was, it was adhered down. Okay? That it will integrate into the body, especially at week 3 and 4, based on that clinical evidence I told you that they did on the 50 healthy patients. At week 3 and 4, there was a huge pro-angiogenic response where Dermapure just took big time out of the gate. So why do I say this? I say that because right here, week 2, the doctor says, well, hey, I don't see much happening. I don't see a whole lot of change. Give it time, doc. It's around week 3 and 4, based on the clinical evidence that we have, where Dermapure has a pro-angiogenic response, big time granulation. So at week 2, hang tight. Look at week 4. There's a 2-year shelf life for Dermapure. It's stored on, like I told you, the shelf in envelopes, room temperature. There's been 0 recalls or stockouts to date. Every envelope, there is a bidirectional tracking card and labels. Your circulator nurse will need those labels. She puts them on the patient's chart. She can also put it on our little tracking card and send it back to our tissue bank that we own in San Antonio, near San Antonio, Texas. Okay. We also have identification of where each Dermapure graft is going as well. So in that envelope, we used to have paper cartons, no longer. The envelope, she can reach right in, take out the labels, tracking card, and Dermapure. It's not sterile. The package of Dermapure. But inside that package is a sterile pouch with Dermapure. And inside that sterile pouch of Dermapure, this smaller pouch, Dermapure will be inside a little screen mesh. You tell the scrub tech, take it out and place it in 400 cc's of saline. Pour some saline in that basin. They're just going to rinse off the glycerol. That's all. They don't need to hydrate it. They're just rinsing off glycerol. 10 minutes per the IFU. That was placed on it before it was sterilized, okay? They know, every hospital knows, if they cut off pieces of the graft, they're going to dispose of it per their facility biohazard policy, usually red bags. It's latex-free, guys, and there's no reprocessing once that package is open. I mentioned to you briefly, Distributor Depot is our additional training website for you guys, okay? I am your clinical affairs manager, your clinical specialist, if you will. Feel free to call me, email me. I'm here to support. Jason will direct you to me many times if you have questions of application or wounds, or if we can help you, even with Zoom calls to physicians, to dive deep into the science if needed. Okay, that's what clinical is here for. But our Distributor Depot website will contain 4 additional training modules, just like today, but a little different. They're 15 minutes each, and you can take those as many times as you want. There's no testing. It will contain all of our brochures that you can download and PDF out to your customers. It will contain multiple case studies and our clinical evidence. Okay, those items that are able to be downloaded and sent out, they'll be on there as well. Multiple case studies that you can download, PDF, and mail out to your doctors, clinicians. It'll be up. We're just making a few modifications to it. It should be up and running by the end of the month. So very important. If you take pictures of a wound and you want to show me or anybody, you really need to have patient permission. You need, because of HIPAA. Okay. So I will send, Jason can send this out to you because I don't know, there's so many on the call. I don't want to miss anyone. But if you would like this and you need to take pictures, please reach out to myself or Jason, and you can have, before you go to the case or in the OR, you can have the nurse have the patient sign this. It's given permission actually for you to even be in the case, but also if you were to take pictures. Down the road, maybe we want to build a case study, but this would need to be signed by the patient before that ever happened. Okay. Complaints policy is very easy. If you get a complaint, there's a big black hole, anything. This is with any graft company. If you get a complaint, please report that to Jason or to myself or to the 800 number on the packaging. Okay, and if they can't use that one and you have to open another package for some reason, yes, notify us, and they'll want the hospital facility to hang on to that, and we'll send shipping information for them to send that back to Cellrite, to our tissue bank. Okay, guys, we covered a lot of information, but we are done. What questions do you have? Any questions?
Somebody's got to have a question. I guess not.
Hi, this is Tenobia. This is Tony in Houston.
Hey, Tony.
Hi. I had a question around when we talked about the differentiators, the 4 differentiators. Can you just go over why each of those, I would say, are important?
Oh, yeah. So when I hired on even 6.5 years ago or so, I sold Graft Jacket in my past. And I said, hey, what do we have that they don't have? What's the difference? They're both allografts. D-cell technology. That is the differentiator, guys. Okay, one, our processing is our own special recipe, if you will. It's unique, proprietary only to Tissue Regenix. Okay? So Graft Jacket, they have their own recipe. Alloderm has their own processing, if you will. Okay? So D-cell technology is comprised of 4 key fundamentals. And those 4 are, 1, we use a low concentrated cleaning solution, anionic cleaning solution, SDS. It's not harsh, okay? To clean, to remove cell debris, donor cells, right? Number 2, and I don't have the screen pulled up right in front of me, but I even used, when I first hired on, an acronym, PANT, to remember them. P, protease inhibitors, preserves the biomechanical properties, but it also preserves the tissue structure. Okay? Protease inhibitors. Not every company uses that. So protease inhibitors, the tissue structure would be your open and tap vascular channels, collagens, laminin, hyaluronic acid, heparin, growth factors. We need that to be protected. Okay? Protease inhibitors. And then A, for that acronym, PANT, A, anionic solution to clean. And then N, nuclease treatment. Removes almost all the donor DNA, right? Greater than 99% of DNA removal. I cannot take your tissue. Let's say, Tony, they took your skin and wanted to place it on my wound. It has to be processed. If they took your skin and put it over my wound to cover it up and did nothing, my body would reject it. It's going to fight it. Your cells, okay? So nuclease treatment removes almost all the DNA from the donor, greater than 99%. And then T for that little acronym is terminally irradiated, gamma irradiated, 10 to the negative 6. That is the differentiator. There's a lot of allografts on the market, but they do not have D-cell technology. The only one that does is Dermapure. The D-cell technology originated out of the UK Leeds University by a doctor scientist husband team, Dr. Eileen Fisher, and Dr. Eileen Ingham and Dr. Fisher, actually her husband, scientists, doctors. In 2000, they founded D-cell technology. We spun off to become Tissue Regenix, become a company in 2006, and it was commercialized here in the U.S. in 2014. Okay. So I'd use that tagline if I was going out to see a doctor. Hey, do you have a minute, Dr. Green? I would like to tell you about a next generation D-cell dermal allograft. What do you mean next generation, Dana? I could hear him saying, well, it's a way we process the tissue. Our processing is different. called D-cell technology, and then I'd go into that. Did that answer your question, Tony?
Yes, it did. Thank you.
You're welcome. And again, Distributor Depot will be up and running soon. There is a registration process. So if you reach out to Jason, he will give you the login information for Distributor Depot. Like I said, it'll be ready at the end of the month with the all the updates, or if not sooner, but by the end of the month it should. And you can, again, watch these training modules as many times as you would like.